The first abstract concerns retrospective prospective harvest of patients that entered the TFR in Italy that unfortunately wasn't able to participate to very large studies on TFR. So we decided to set a registry and see how was the practice for TFR in Italy and if it was diffused and since when and which were the reasons to entering TFR. And of course, in this same registry, a group was extrapolated in which TFR was kind of mandatory because patients wanted to have a baby or were already pregnant. The first important thing is that, of course, not all the patients entered the criteria for TFR. As a matter of fact, more than half of those patients were just in major molecular remission or less. So they were not in deep molecular remission, and they were not in deep molecular remission since at least 2 years. The fact also that they were younger patients is one point that may explain the differences that we saw about the outcome of TFR in the two populations of patients, the extrapolated pregnant population and the non-pregnant population. In the first group, the outcome was very good. Usually the patient had entered TFR either because they had some side effects or because they had the criteria and they wanted to try stopping the drug. And the outcome at 12 months was around 73% of patients that were staying in TFR. While from the pregnant point of view, that was of course a lower number of patients, this percentage was dropping around 40–50%. Patients didn't have any problem in carrying on the pregnancy. They stopped TKI generally at first pregnancy test. Some entered the TFR before conceptions, but all were free of drug in the organogenesis period that is the most critical for teratogenesis, because the organ formation develops among the 5th and the 12th week of gestation. After the 12th week of gestation, placenta is formed, and some of the TKI cannot pass the barrier, the placental barrier, or they pass it only in a small percentage, and they may be considered for restarting therapy. So considering the patient that stopped TKI during organ formation and generally throughout the pregnancy, all pregnancy were uneventful. The babies were fine, and some of the patients had to start again therapy. Most of them were treated with interferon. Some were treated with either Imatinib or Nilotinib, but after the placenta was formed. So the conclusion of this study is that there are many patients that are willing to enter a treatment-free remission phase because of pregnancy. We can manage also those patients that will not require the criteria for a TFR. They must be managed, of course, individually, and a team of doctors, hematologists, neonatologists, and OBGYN are preferred to manage from an interdisciplinary point of view this moment. But this is feasible, and planned pregnancy can be carried ahead as well as unplanned pregnancies.